Stop talking to people. I want all.
I'm coming.
That's the number that you call or you WhatsApp.
0725
000 222.
Okay. And if you SMS the word plot, where do you send that to?
You send that to 20321.
Plot.
Plot.
To 20321.
Okay.
If you come through to them, City, you'll find username investment people on the other end.
Yes, you
They'll
will.
tell you about Serenity Springs.
They will.
And they'll tell you how much an eighth of an acre is going for.
They will.
And what else will they tell you?
They will also tell you that unlike certain developments where you will be met with earth that has not been trampled on for the longest time, perimeter fences that were pronounced but don't exist, madam roads that don't exist, boreholes that don't exist. With Serenity Springs, everything
Exists. Okay, sorry.
what has been no, you're absolutely right. Everything the above clearly stated exists. Yes. And the price that you are told you are required to pay will not change. It is that same price. And it includes everything that has been mentioned. And neither will it change in the near or in the future.
Bas.
Kabisa.
Yes. If you'd like to visit Serenity Springs in Lanette and you're in Nairobi or in Mombasa or wherever, take the Nakuru Highway. Naivasha. Elementaita. All the way.
Gilgil.
You get to Gilgil Elementaita and then you get there. Once you get there, my friend, yes, you will, before you get into Nakuru city proper, you'll get into Lanette. Another way, this is Safari Rally weekend and people are going to be in Naivasha. And that whole area between Naivasha and Elementaita, so it's going to be busy. And you're thinking, oh my goodness, I'd like to avoid that traffic, but I'd like to go to Lanette. Even Kenha is saying, you want to go that side? Actually, there are various other routes that you can use. Leave Nairobi, Rironi. You get to Sokomjinga, right? When you're in Sokomjinga, by the way, you have left Nairobi, you left Kiambu, you're now there in Nyandarua County.
Yes.
Sokomjinga, there's a flyover. The place is called Flyover because of this interchange that has the overpass. Take that overpass, and then you will get into Jabini. Jabini. In Jabini, look around the land. You will see, you'll understand why they say cash crop ya Nyandarua ni mawaru. Because that's what they're growing. You will get to a place, small to towns. One of them is called Engineer. It's a town past Jambini. Okay? Then you'll get to Olkalau. Then tell them, Olkalau, how do I go to Lanette? They'll tell you, take this route, you'll get to Oljoro Rock.
They didn't go to the two.
Oljoro Rock is now the Ndondori into Lanette.
And from Lanette to Nakuru City.
So when you get to Lanette, you'll see username. This is the color, green and red. You'll see the posts, green, red posts. Just know, I am here. I am in Lanette. Ask them, where is Serenity Springs? They'll tell you, unaona ile gate pale. Ingia hapo. Umefika. Okay? Yeah. So then you'll get to use the Ndondori scenic route.
The two Ndus, yeah.
From Jabini to Engineer to Olkalau to Oljoro Rock to Ndondori.
Thank you very much.
To Lanette.
We are here.
We're here. 0725 again, 000-222 is the number to call them. Let's talk about health. So we have heard doctors' strike has entered the 13th day. Clinical officers are threatening to go on strike. Lab technicians are saying they want to go on strike.
1st of April.
I don't know, MPs are threatening to impeach the minister. All those things are happening. The point is, when people are going to seek health services, are they getting the health services that they want? The Director General of Health is Dr. Patrick Amoth, currently still in an acting capacity. He's our next guest in the Situation Room. Dr. good morning.
Good morning, Eric.
Welcome to the hot seat of the Situation Room.
Thanks for having me.
It's good to have you here. We will be discussing very many things that we've talked about. As the boss of provision of health in the service in the country, you have a lot to tell us and to educate us and to answer. CT will first give you the day's proverb. Every week he goes to one African country, then he brings us proverbs from that country. What we'd like you to do is listen to the proverb and give us your interpretation of it. Are you ready?
Ready?
Very good, City. Go.
Yes, the cleverness of one alone is a shallow well that soon dries up.
The cleverness of one alone is a shallow well that soon dries up. This is a proverb from
Mauritius, the island republic of Mauritius. Yes.
Dr. Amoth. What's your interpretation of that proverb?
Nice proverb. My interpretation is that you cannot be able to do everything alone. You need the rest of the community, the rest of the people, so that we can be able to prosper and move forward together as one big people.
City?
He has interpreted it very well. It's clear it speaks to him in the manner he has just mentioned. Yes, and he understands you cannot do these things alone. This Lone Ranger mentality where someone thinks they can do everything on their own is completely misguided.
Westmake.
Nah, you need others.
You need others to walk the journey with you. Dr. Amoth, what's the job of the Director General of Health?
The job of the Director General of Health is one of those jobs that is prescribed in law under the Health Act 2017. And one of the responsibilities of the Director General of Health is to be able to advise the government on all health matters in the health sector. Number two is the principal technical advisor to the Cabinet Secretary. Number three is to advise the two levels of government on health-related issues. Number four is to prevent introduction of diseases into the country. Number five is to be able to support data generation and research on health matters. Number five, the Director General is also responsible for the internship program. And six is to be able to advise the ministry on licensing of health facilities. And usually there's a caveat in all the description as any other responsibility assigned by the appointing authority, just to name but a few, so that you don't leave anything to chance.
Yeah. So basically, the Director General of Health should be a doctor. For you to offer all these advisory services and to oversee all these things, you, by expectation, should be a doctor, isn't it?
By the definition and what is in the law, yes, that is true, according to the Health Act 2017, Clause 17.
So I'm right to say that you're the senior most doctor in the country.
By virtue of my position, but I have also my seniors who taught me who are working in various sectors.
Okay.
Yeah.
All right. So when we have a smooth running health sector, we have a lot to thank the Director General of Health.
True.
Similarly, when we have challenges in the provision of health, in accessing health, we have a lot of questions to pose to the Director General of Health.
Correct.
Okay, let's now start posing the questions. Currently, doctors are on strike. 13th day. They've been raising issues. There have been meetings in the ministry. There's been about implementation of CBAs. There has been an issue of posting of interns, medical interns, plus others. Why are we where we are today?
We are where we are today because one of historical issues, two, the changing ecosystem in the health sector. For a long time, we only had one medical school, the University of Nairobi. Now we have 13 medical schools. So the total number of people we are churning out in terms of our graduates from our training institutions has increased. While in terms of our guidelines, our policies, those policies have not changed in tandem with the changing ecosystem. So, for example, what we are going through now in terms of the placement of interns is a question of, and we need to look at this through the entire value chain, from entry point into the training institutions, the exact training program, and where we get the products or the outputs, and the end consumer of this product or output, which is principally the Ministry of Health and of course the private sector and the faith-based organizations. So for a long time we have operated on the paradigm that the numbers were manageable. If you look at the total number of interns that have graduated over the 10-year period, the number has increased threefold, from 214 in 2014 to around now 880 something, close to 900. That number has increased despite the allocation for the Ministry of Health for the internship program not increasing in tandem with the increasing numbers. And of course, that increasing number also brings other issues, including where do we place them, because we have a fixed number of internship positions in different facilities. And because internship is principally an experiential learning, where you're supposed now to translate the theory that you are taught into medical school into clinical practice, how you can be able to examine a patient, how you can be able to pick a specimen, how do you communicate with the patient, then it is imperative that the numbers then are also in tandem with the facilities where this training is going to take place, including the necessary infrastructure, the necessary human capital, in terms of the health specialists, because internship you work under supervision of medical officers and the specialists. So basically for now the problem has been underfunding in terms of exchequer. And we noted this in 2023, the Honorable Cabinet Secretary communicated to her counterpart in the National Treasury requesting for additional funding to be able to support the internship program. The response from the Treasury was that it is no longer sustainable with the numbers that we have, and the Minister was advised to be able to develop a policy position to look at the numbers that could be sustainable within the fiscal space that obtains us at now. And in the final comments of the CS Treasury, one is that the budget 2023-2024 was being implemented under tight fiscal framework and with the projected revenues not meeting the objectives, and also increased requests or requirements for payment of other priorities, including loans. And therefore, we are advised to rationalize what we have within. And as a result of that, our request was not honored. So basically, that is the genesis of this problem.
Okay. So now that's where it all started. That's what's currently going on. The number of things that you've said even before this is that you said one of the problems that plagues this arena is that policies that have gone over time unchanged. So that's one. Now, when you put that together with some of the issues that you've talked about here, fiscal framework, tight fiscal framework, what is not available, rationalize things that this arena, again, has previously done. What would that mean, and would it make sense then if one of the things they said was, okay, let's not send the number of interns that we are sending out into the different spaces, let's reduce on that number? Would such a thing then make sense from a health services point of view?
It will make sense from a fiscal perspective. But of course, if you look at our numbers in regards to the health workforce that we require vis-a-vis our population and our demands, that is not a good thing to do. But so it's a dilemma kind of a situation where you have to balance things out. Here you don't have sufficient numbers, but on the flip side you also don't have the adequate resources. So you need to be able to balance and find out what can be able to work for your population. And one of the things that we did was to be able to have a paradigm shift in delivery of healthcare services in this country. Ever since we got independence, our health service delivery has been curative driven. You get sick, you go to hospital. In fact, our national health insurance scheme was called the National Hospital Insurance Fund, meaning you could only be able to access that service if you are in a hospital. If you are in hospital. So we are basically funding sickness. But now what the global world has told us is that it is better to prevent disease than actually deal with the sickness. And that is why we have had this fundamental shift towards primary health care, based on a strong community health system, trying to use the community health promoters as people to help us in basic things, but also to increase demand generation for healthcare services through a preventive promotive approach. Knowing very well that even the WHO has projected going forward that the global community is going to have a shortfall of 10 million healthcare workers. 45% of that shortage will be in low middle income countries, mostly in sub-Saharan Africa. So for the foreseeable future, we are going to have a challenge in terms of numbers of healthcare workers. And the best way that we have been told global world over to be able to achieve universal health coverage is by investing in primary healthcare systems, because these systems are inclusive, they are comprehensive, they promote inclusivity and equity, ensuring that nobody is left behind in terms of health service delivery.
Okay. The number of institutions that were offering medical education, like you said, we've increased from 1
to 13
now. The number of students graduating with a medical degree has increased to 214 just 10 years ago to close to 900.
Close to 900.
Presently.
Those are locally trained graduates.
Locally trained.
Remember, there are also graduates who train outside.
And
Kenyans who go to Tanzania, Kenyans who go to Ukraine, Kenyans who go to all over.
And India.
And they come back.
And they all come back.
That is another 500, around 500.
Every year?
Yes, graduates every year.
Okay. But we've been knowing this. We have been seeing it increasing. I mean, it's government that licenses these institutions and allows them to offer these courses. The Ministry of Health can see this is happening. We have X number of students now in school studying, and they're there for 6 years. So surely it's not like a 6-month course where you may have turned the other side. What has happened over the years in terms of the Ministry of Health communicating to the National Treasury, communicating to Parliament on budgetary allocation?
That communication always takes place, that we need more funding. But that communication that goes to the National Treasury, to Parliament, comes from all state departments in the government. Yeah? So here you have one piece of cake. Everybody's angling for this cake. So the parent or the father or the mother who is distributing this cake ensures that Muga gets a small piece, Eric gets a small piece, Ndu gets a small piece, Amoth gets a small piece. So in summary, what we need to do is to be able to bake a bigger cake so that everybody's needs are satisfied. But you have raised something very fundamental in terms of our visibility in the training institutions. Eric, you may be aware of a judgment that was passed on 11th of June 2020 by the High Court regarding Commission of University Education and various regulatory bodies. And the judgment was that it is the Commission of the University Education which has the oversight in training institutions, not our regulatory bodies. So as the CEO of Kenya Medical Practitioners Dentist Board, or Chairman, Professor Hainga and Dr. Kariuki cannot walk to the University of Nairobi to be able to inspect that training institution. How many doctors do you have in this class of 2023? How many lectures do we have? How many laboratories do we have? So we have no visibility, and we are disbarred by law to be able to visualize the end product that we are going to use.
But it doesn't bar you from communicating to the universities. You know the 13 institutions that are going to be sending students to you for internship.
Oric, there's something also that fundamentally happened in this country a while back. This problem was not there when we used to have the regular program alone. When we started having the parallel program, which is a good thing, so that we can be able to make education accessible to all, I think the interpretation of our teachers regarding the parallel program was not correct. The parallel program has been interpreted as a source of revenue. And now we are battling even with quality issues because the numbers in terms of the space, like for example, the Nursing Council of Kenya has clear, and even the Kenya Medical Practitioners Dentist Council has clear regulations regarding the size of a class, the number of lecturers that should be able to run that class, the number of other facilities required to ensure that you receive quality training. But that is not happening. And in fact now, because of that lack of visibility, you find universities starting courses that are usually only offered at specialist level. Somebody tells you, I'm going to give you a course in epidemiology and biostatistics. From where we sit as a ministry, as an international community, we know epidemiologists are super specialist trained people. Then they come to the ministry that my daughter, actually I've received like 4 or 5 letters. My daughter trained in this university and cannot be registered to practice. So how do we register you to practice epidemiology and biostatistics? And yet we know our epidemiologists, you must get a fundamental degree in medicine, then you go and now study this deeper and deeper. So definitely we need to have a conversation with the training institutions so that we can be able to align this.
Am I hearing you say that there is a broken system in how we are training our health workforce? Because training is not complete, even according to the law. The training of a doctor is not complete until they have completed the internship. True? So that they can then be registered by the Kenya Medical Practitioners and Dentists Council as a doctor.
Very true.
And this internship is the purview of then the ministry and the council at the end. But you do not have any say in everything else up to that point.
That is why I talked of the value chain, that we are missing in action at a very important part of that value chain, and we need to have this conversation so that we can be able to correct all this that have not gone the right way.
But still, Daktari, I'm still at a loss to imagine that graduates come to you in the last moment with a medical degree seeking to be placed for internship, and that you do not know. For example, you're saying you do not know how many will be graduating this year out of these 13 universities.
That number is now visible because of the coordination that we have put in place through the training institutions, through the Kenya Medical Practitioners and Dentists Council. And because of that, we changed even our posting system, because previously we just used to post interns once. Now we have had to change because of the increasing numbers. Now we do the first posting in Q1 of the financial year, and then we do the next posting in Q3 between January and March. So it is not something that is entirely, it is something that we have been looking at, discussing with the relevant sectors, including the National Treasury, the education system. You remember sometimes in 2022, we had a big conference in Mombasa, which was opened by then His Excellency President Uhuru Kenyatta, to be able to look at this fundamentally, yes, bringing all those actors together. That is the conversation. This is where this conversation began, and it is good that even during this strike, we need to be able to bring all these pieces together so that we can be able to address this matter once and for all. We address it for futuristic, for posterity, so that we have a system that is functional and in its entirety, despite the shocks thrown at it.
Okay, let's take a break. We'll continue the conversation shortly with Dr. Patrick Amoth, the Acting Director General of Health and Ministry of Health. He's here so we can discuss the state of healthcare in this country. Which way forward? We are seeing these strikes, they're becoming sort of like a norm. We are seeing issues with provision of health services, the quality of healthcare being provided in the country. All these questions need answers. He's here to provide those answers. We'll be back shortly.
This is the Situation Room, the only way to start your day.
Looking for top tips?
Warm yourself up for more sports, more action, and more fan celebrations on Star Times. On Star Times. Stream and catch up on your favorite games. Download the Star Times On app now. Star Times. Enjoy digital life.
Nitachukua kalamu na kitabu mimi niandike. Lazima mwaka huu nitapata haki yangu. Uone wako umekwisha, kilio kimekoma. Baraka yangu ilikopita itafichuliwa. Overflow, mwaka wa baraka. Nitakumbuka mimi.
Habari njema, mchezo mpya kushinda hela umewasili. Tazama utuzwe ni mchezo rahisi na njia haraka ya kushinda hela ukitumia simu yako. Kuwa mmoja wa mamia ya washindi kila siku. Jishindie kuanzia shilingi 20,000. Ni rahisi. Deposit kuanzia shilingi 20 hadi 99 kwenye paybill number 145656. Account number KTN. Shinda sasa hivi. Draws na washindi kila hour. Kumbuka, deposit kuanzia 20 bob hadi 99 bob kwa paybill number 145656. Account number KTN. Na unaweza kujishindia hadi 1,300.
A twisted story of revenge that will steal your heart. A daughter will bear the punishments for the sins of her mother.
Vengeance is soon going to be mine. Their lives will be ruined, and a daughter will bear the punishment.
This is not a love story. It is a story of hearts broken by revenge.
So what?
Broken faith.
Only on KTN Home.
Bado potea.
Na kwa nini unakucha pasi kama umelalia kitanda yangu?
Sasa hapana kuwa na wasiwasi. Sauri sisi taishi na wewe ndani ya hii nyumba.
Hebu wacha mchezo please. Wacha mchezo tafadhali. Kwa tutaishi nawe kwa hii nyumba, kwani wewe ni pipi yangu?
Kwani mtu naisigi na bibi peke yake?
No, wewe ni pipi yangu ndio nakuuliza.
Nini mbaya?
Fisi ni mnyama.
Haya.
Sasa
usinifuate. Tafuta mtu wa stima ujinyonge.
Sasa mtajinyonga namna gani?
Usinifuate. Na usinifuate.
Hakuna haja. No, you cannot please.
Usinifuate.
Sasa nini? Kwa nini sweetheart? Mbona sasa ile tija unaniletea?
Fagilia wote.
Lack of, re-strategy. So, with the doctors having down their tools today, with clinical officers, lab techs threatening to do so tomorrow, or the next week, because of fundamental commitments having not been met, and we can't deny that, is such action then justified in the face of it? And would that be then an adequate push for these conversations, which you've admittedly stated need to happen, need to be fixed? Is it justified for that purpose?
Thanks, Do. First of all, strikes are very unfortunate events, and effects of strike disproportionately affects women, children, elderly people, people with disabilities, people who live in underserved areas. Because these are all other people can be able to access alternative health services in case of a strike. That notwithstanding, and the pronouncements of the courts, both the Labor Relations Court in Labor Employment Court in Nairobi, Order number 6, and the High Court ruling in Kisumu, filed by the Kisii County government, that outrightly declares the strike illegal. I would still want to appeal to my colleagues that we come to the negotiating table, go back to work, we negotiate on these things. You remember the Kenya Kwanza government is one of those bold governments that actually puts the issue of health on its manifesto with clear, tangible goals.
Yep.
But that notwithstanding, this is an opportunity for us to be able to discuss these things once and for all, and be able to generate a discussion and come up with tangible action points. It does not matter how long we are going to settle them. We have those things that we can be able to deal with immediately, like the issue of payment of the basic salary, which, like for example, the national government has paid to the fullest. In fact, we demand a refund of 81,000 from the doctors because there was an excess payment. There is the issue of the comprehensive medical insurance services. 36 counties have enhanced schemes with various insurance providers. And the national government employees, of course, has a scheme under the Ministry of Public Service. Our level 6 facilities have their own private schemes. Again, that is something that we can be able to thrash quickly over the table. And so we can be able to tick the boxes regarding these 19 action points raised by the union. Then there are those that require medium to long-term approach because of the budgetary constraints. And there's a budgetary cycle prescribed by law that we have to follow. Then we can be able to prioritize those ones in order of what we think is important and then deal with them and give them even a timeline. It may not be possible to solve all these things in 2-3 years, but maybe a time frame of 5 to 10 years, we can be able to deal with these things once and for all.
But Dr. Amoth, one of the issues that they have raised is that these conversations have taken place before and that there has been a commitment from across board, but unfortunately, they've not seen these things being done and that it is easy to hide under the cover of the reason of lack of resources, whereby there are some things that you can actually do without the exchequer then taking that problem on their shoulders. The institution of a health service commission, for example, something that they've asked for forever. Some of the contracts being made, we understand that it has, a resource responsibility attached to it as well. But one of the major issues that they do bring up is that every time there's a threat of a strike, there's a promise to ensure the commitment is fulfilled. But then when they do go back to work, that commitment then is put on the back burner and is not dealt with. What would you say about that?
Thanks, Do. Let me take this with the rear view mirror. Before we launched the Universal Health Coverage Program in Kericho on 20th of October last year, we had initiated a discussion with the unions, the professional associations, the academic institutions, the civil society. We came up with an 17-point, 18-point action plan. And some of the things that have led to this strike are squarely within those 18 points that we raised. We generated together at Windsor Golf Club. In our approach towards universal health coverage, we also had pillars, and one of the pillars of UHC is human resources for health. And in terms of sequencing, we have 4 pillars. Pillar 1 is self-financing. Pillar 2, health products and technologies. Pillar 3 is the digital health information system. And Pillar 4 is human resources for health. And Pillar 4 is the living pillar of all these, because it is the one that has the human face. And in terms of sequencing, we said we can be able to quickly turn around the health financing, change, and you saw the laws that we passed to be able to move from NHIF to now Social Health Authority. In terms of health products and technologies, again, we thought that was a low-lying fruit. We could be able to take administrative decisions, give additional capital to KEMSA, make changes here and there in terms of composition of the board. Again, that has been done, and now our order fill rate has improved significantly, especially for essential medicines and medical supplies. And in the digital ecosystem, again, that has moved, and we are working with a consortium, including Safaricom and the big hitters in the telcos, to be able to change how we deliver healthcare services. The human pillar of UHC is the most difficult pillar. And therefore, we had proposed that upon the launch, then we can continue to have this discussion. Unfortunately, now we're in the strike, but it's good that some of the things raised in the strike are the things that we had planned to discuss. So that tells you the goodwill of the government, that we had thought about this beforehand. We had initiated those discussions. However, now we are in this situation. And therefore, what I plead for is that this discussion needs to take place. And this goodwill from the government, we should seize this goodwill, especially my colleagues from the union. Let's seize this moment and see, this is a different government, maybe things will work out differently. And that what again emboldens me when I sit here with you is now the direction again of the court, that some of these things are so fundamental that we need to address this as a whole of a nation approach under the leadership of the head of public service. The honorable judge in his wisdom must have looked at those things and said, this one cannot be sorted by the Ministry of Health alone. Let's bring the entire government and the entire society, so that we can be able to have this honest conversation.
So now, what's the way forward? As you sit and you're looking, because human resource for health is where we are at right now. The various issues, unpaid dues, some of them saying, there are conditions for work not conducive in terms of provision of health health insurance. Looking at the training of healthcare workers and them not completing their training because lack of resources. What's the way forward?
It is no simple solution to this problem. The way forward is that we need to be able to have this honest discussion, leverage, lobby, bring everybody into the space so that we can continue to prioritize health services in this country. We have made significant progress, Eric. In 2023, last year, in April, we released the data for Kenya Demographical Survey. And this looks at fundamental health indicators for the country. I can tell you without fear of contradiction, more children are living to see their 5th birthday. More mothers are attending. In fact, our target for mothers attending antenatal clinic was 80% by the year 2030. We are 90% at the year 2022. And investment in health is an investment in the economy. We should not only look at health in terms of as a service delivery thing, but we should also look at it from a microeconomic and macroeconomic perspective, that if we invest in health, people who are healthy, they are likely to be more productive, and they will be able to spur economic prosperity. The other thing that is that investment in health, if you look at the healthcare workers, the majority of healthcare workers are women because it's a service industry. So through that, investing in health, we also promote inclusivity, gender parity, and women empowerment. And therefore, that makes us move together as one whole nation instead of leaving people behind. We should continue to prioritize investment in health because of its many beneficial effects.
The implementation of health and this devolved system of government has had its hiccups. And the healthcare workers have been saying, because we are dealing with 47 different employers, and then there's the one employer also who's national government, who also has some of our doctors, maybe we should harmonize this and have one commission. What's your view on this matter that has been pushed by doctors for so long? Have one central health services commission that employs and then attaches doctors to facilities or counties?
Thanks, Eric. Again, I told you the health workforce is probably the most important element of any healthcare system. It takes more than 60-70% of the total health expenditure of any healthcare system in terms of wages, stipends, salaries paid to healthcare workers. And we saw the importance of this element during the COVID-19 pandemic. You could be able to have the latest machines. You could be able to have all the money on planet Earth, but your people will still die if you don't have healthcare workers.
Yeah.
That is a good suggestion to have a commission, but that I don't think is the one, is not a panacea for all our problems. We have the Teacher Service Commission. Do you have all the teachers that we need for our schools?
No, we don't.
No.
Are teachers not threatening to go on strike even as we discuss now?
Yes.
Actually, let me answer your question. Do we have enough teachers for the schools? We do. Do we employ enough teachers for our schools? We do not. Because we seem to produce more teachers than we can employ. And it appears like, same with healthcare, we seem to produce more healthcare workers than we can employ.
True.
Yes.
True.
So the anomaly lies there.
So why aren't we employing? Because of the size of the cake? Doctor, is that what you're going to say?
I told you my job description, and none of it deals with anything finance.
You are the principal advisor to the Minister for Health.
On technical matters.
On technical matters of health.
Yeah.
And therefore, by extension, the principal advisor to the President on matters of health.
True.
And the advisor to the government on matters of health.
The two levels of government.
Right?
Yeah.
Both levels of government. Yeah. So when it comes to matters such as ensuring that we are meeting our need for healthcare, you are the one who would say, look, with this kind of population, with this kind of needs, we need this number of doctors. And then you would also say, then we therefore need to graduate this number of doctors. We need to register this number of doctors. We need to retain this number of doctors in the country per year. You're the one who's doing that. You implemented the Jubilee administration's universal health coverage under the Big Four agenda. You are now implementing the universal health coverage under the plan of the Kenya Kwanza administration. You're right there in the middle of it. What are you advising them in terms of the number of doctors and healthcare workers that we need in the country and allocating money for it? If you don't, like you said, you may have the best equipment, you can work on financing healthcare, you can do products and technologies, but if you do not have proper human resource for health, the entire health system will collapse. What have you told the president?
Thanks, Eric. Very good question indeed. And we have done some work in that space. One, last year, we did what we call the health facility census in preparation for universal health coverage. We sent healthcare workers from the counties, from our affiliated institutions, our SAGAs, and the national government to visit more than 14,000 health facilities, public, private, faith-based, including standalone clinics. We generated a very, very good report, which was launched towards Christmas. I think that is why it never received the public attention. To be able to tell us where we are as a country in terms of infrastructure, in terms of equipment, in terms of human resources for health. And one of the things that comes out of that report is that the WHO guidelines, as at now, we require about 23 healthcare workers per 10,000 population. We are at 10 healthcare workers per 10,000 population. Out of the 47 counties in this country, 12 counties have achieved that global target. Therefore, 35 are lagging behind. But don't look at this target just in its absolute numbers, in absolute entirety. We also need the skills mix and the distribution to be equitable. If you have achieved that population, that ratio, but your healthcare workers are only in the urban settlements, then again you are not on the right trajectory to be able to achieve universal health coverage. Number two, there's a document that we are supposed to launch called the Health Labor Market Analysis. Now looking at that entire value chain from production, absorption, those who have not been absorbed, attrition, deaths, and even the number that we can commoditize, the number that we can be able to export outside through bilateral labor agreements and like the one we signed with the UK. That report is ready. But that notwithstanding, still because of the tight fiscal space, we anticipate by 2031, we'll have a shortage of nearly 100,000 healthcare workers.
By 2031?
2031. Nearly 100,000 healthcare workers. As at now, we have a total of about 190,000 healthcare workers. Our doctors who are in both public, private, and administrators like me, I'm also counted as a healthcare worker, though I don't provide direct service. We are about 13,000. So doctors perform about 6% of that entire health workforce. And it's also important to know that healthcare workers work as teams. And therefore, you should not be able to just look at one facet. We should not be able to discuss these things in silos. There's the role of the nurse, the role of the clinical officer, the physiotherapist, the pharmacist, the dentist. Together collectively is how we can be able to deliver wholesome service. So we have the numbers, we have the projections, we have the cost estimates, and I will not be able to disclose that now because the report has not been officially sanctioned. But that is one point of our conversation going forward.
Okay.
So that tells you we have tried to look at these things from a fundamental perspective so that we can be able to deal with the root cause of this perennial industrial action.
Then, Daktari, with UHC being one of the big 5 in the Kenya Kwanza plan to make sure that it's implemented, this president even has his own technical advisors on health matters, on universal health coverage. You, as the senior most medic, you have all this data and information and saying, we need to make sure that we are training doctors, we are bringing doctors who are either training locally and abroad, they go through internship, we absorb them so that we can deliver health services the way we need to. And this is how much we need. It then does not sit well with me where a conversation then happens on, you need to send interns, we don't have money. Please explain to me, is it that the explanation given at cabinet level, because this matters, the budget is discussed by cabinet before it's taken to parliament. The Minister for Health sits there and says, this is my need. And my need, because I am supposed to provide training for healthcare workers, I need X for training. The National Treasury CS can sit across the table and say, I don't have enough money. What would the boss say? I need to deliver universal health coverage. Is it that the message is not packaged well enough to be understood by all?
I think the message is clear to everybody except the situation that we are dealing with, the fiscal space. I think that is the problem. And it's not unique to Kenya, including the developed world. Despite the resources like UK, for example, there's still shortage of health workforce in the UK. It's not that they don't lack money. If you look at the health outcomes of the United States of America, despite that investment, it's not only money. If you look at the health indicators of USA compared to a country like Costa Rica or Cuba, for that matter, you'll see the disparity. America per capita expenditure on health, more than $5,000, $7,000 per person. Costa Rica, maybe 1,000 thereabouts. But if you look at the outcomes, different. So the question is not only about money, but
Doc, which of those countries that you've given as example has a drop in the point of training? Because posting of interns is still on training. True. We're not even talking about absorption at this point. If we are not finishing training of doctors because of financial constraints, which other country can you give as an example that has trained a doctor for 6 years but cannot register this doctor because this doctor
that is really,
has not completed?
Even Tanzania now currently is dealing with this problem. In fact, the proposal for Tanzania is that instead of now paying, having the interns leave college and do 1 year of internship outside, they are proposing a radical departure that they do that final year, it becomes part of their training. Okay. So, and even Morocco, that is the way it happens. Yeah? So you do everything, internship is when you graduate.
Okay, but now if we look at what's happening in Kenya today, and we're on the cusp of hoping to deliver UHC, and we're looking at some fundamental things that must be done, do you see earnestly a situation whereby UHC will be delivered in the manner in which it was envisioned with these issues that we see currently happening?
Oh, I'm still very hopeful because I believe this is just turbulence in the system and things will self-correct. But remember, I told you our thinking of UHC, the fundamental departure. I know curative services will still continue, but we believe that if you put a little bit on the primary healthcare system, and studies have been done showing clearly that if you invest a shilling in the primary healthcare system, then the returns are about 13, 14 shillings in return. So we believe if we can be able to strengthen our primary healthcare system, then we can be able to fundamentally change our health outcomes. That notwithstanding, as we deal with the curative services, where the doctors, the interns are still paramount. I'm not saying that the primary healthcare system is going to replace the interns. No, the healthcare system must still function along the continuum of care. That there's somebody who will start from a primary healthcare level and end up in a level 6 super specialty hospital. That care must be provided.
I'm skeptical. Primary healthcare is to be funded from taxpayers, right?
Yeah.
In the current spectrum.
Right. Yeah.
The primary healthcare level 1 from community health worker to level 1, level 2, that should come from the exchequer, from the National Treasury.
Yes.
This same one that does not have money to train interns.
To send interns to their posts for the last 9 months.
Who have ensured that they're actually garnering the finance needed for this system through a different model of taxation, isn't it?
Yes.
So they cannot then say that they do not have money for this.
To send interns.
No. You see, I don't understand. Where's the miscommunication? Training in healthcare. Is it under healthcare? Is it under the Ministry of Education? It's under healthcare.
Under the
Ministry of Health. Yeah.
Under the Ministry of Education.
Education. Yeah.
Precisely. So what we were saying, therefore, is that they seem not to communicate.
Silos. Typical
They
silo
seem not
behavior.
to communicate. Because there is a need, and the need is obvious to all, and yet that need is not being met simply because the principals who should be communicating about this issue, so that the planning and the financing of it is in order, don't seem to be on the same page. But then if it's the Ministry of Education, then they have to be excused. Because everything that falls under the purview is in total chaos at the moment.
No. We have a whole of government approach.
Okay.
As Dr. will remind you. True, Doc?
Whole of government, whole of nation.
Whole of government, whole of nation approach. But Doc, thank you very much for joining us today. It's been an interesting conversation. Please come again.
I will.
Come again for 2 hours so that the public can also get to talk to you.
Yes. There's a lot, especially to understand when it comes to the thinking of UHC, how we roll out UHC, how we then improve our health services, how we even change our own care-seeking behavior about health.
We could discuss about UHC next time.
Asante.
Thank you.
Dr. Patrick Amoth is the Acting Director General of Health. He's been our guest. Keep it here for more conversations, 9 a.m.